So today I'm going to discuss about the frailty assessment in primary care. So, Dr. Dilini? Yeah, right. Thank you. Today, as we all know, our population is aging. So, as a primary care physician, we have a lot of responsibilities towards the population, aging population. So that's why today I'm going to discuss with you about the frailty assessment. Next slide, please.
I'm sorry, seems I can't share it. Just give me a minute.
Okay.
Stop share and reach. Right, okay.
All right. So frailty. What do you mean by frailty? It is a geriatric syndrome which is causing a loss of physiologic reserve of the person, and it leads to adverse health outcomes, and it is giving a vulnerability to adverse health outcomes and the stressors. So basically, the loss of physiologic reserve of our body, that is a frailty definition. So in geriatric, a comprehensive geriatric assessment needed to identify the risk factors and the early symptoms of frailty to reduce the morbidity and mortality of these individuals. There are so many validated tools available, but we will discuss about some, mainly the two validated tools, which is most commonly used in primary care practice. Next slide, please, Dilly. Right. In normal aging, as we know, there are lots of molecular and cellular damage happens. This leads to loss of physiologic reserve. There are alterations in mitochondria and cellular process, and there is increased free radical concentrations. So there is amplification of apoptosis leading to systemic changes. With aging, there is increased immune system activation, and hormonal dysregulation also happens with increased cortisol levels. All these contributes to the loss of physiologic reserve, and the ultimate end result is sarcopenia. Next one. So there are lots of risk factors that identified that leads to frailty. The main non-modifiable risk factor is female sex. Being a female and being age is a most common risk factors. So unhealthy lifestyle, low socioeconomic state, low level of education, smoking, presence of multiple comorbidities, and taking polypharmacy. All these factors contribute to the frailty. So in primary care, the prevalence of frailty estimation is really, really hard due to this multifactoriosity. So there is another thing is there is no special hallmark sign or symptom that is pathognomonic to the confirmed diagnosis of frailty, and as well as a laboratory tests. There are no specific tests to see that this patient is frail. So it is it depends on the comprehensive history and the physical examination. and use of validated frailty assessment tools. With all of these, using all of these, we can assess one's frailty. So there are early frailty symptoms. What are those? For the first one, that is the first one is generalized weakness and exhaustion. The poor balance and decreased physical activity, decreased strength, reduced cognition. All these are early frailty symptoms. When it comes to weight loss, it is typically a sign of a late stage of frailty. So this diagram shows you the frailty cycle. I told the ultimate result is the loss of muscle mass, sarcopenia. With aging, the strength and power of muscles reduced. So this causes impaired imbalance. They may tend to get falls and injuries that will cause immobilization. This reduced strength also leads to reduced walking speed. And due to the power and the strength reduction, the activity also reduced. And with aging, there is reduced metabolic rate as well. So all of these factors reduce the total energy expenditure of aged person. And other things, the diseases in age, like depression, dementia, acute illnesses, sedating medications, stressful lives, and all these factors also contributes to reduce activity and to reduce total energy expenditure. With age, we all know there's reduction in taste, poor dentition, dementia and depression, all these with illnesses and hospitalizations. These people tend to get chronic undernutrition. So this lack of micronutrient and proteins and energy, those leads to negative nitrogen balance, leading to sarcopenia. So these with age and with disability, the chronic inflammation and increase of cytokine levels. And I told you that the cortisol level increase and the catabolic state will go up. And all these also leads to sarcopenia. A lot of factors. So this is a like vicious cycle. So we have to, anyway, to reduce the frailty, we have to reduce this somehow, whether we have to stop or we have to reduce these effects. So we'll see how we can do this in primary care. Next one, please. So early detection and frailty screening is really necessary. This will lead to slow down the physiological weakening process. So frailty, as you know, increases falls. So this leads to lack of autonomy of the person and leads hospitalization and ultimately increased morbidity and mortality. It is a strong predictor in morbidity and mortality. I told about the two frailty tools. One is Fried Frailty Phenotype and the Rockwood Frailty Index. Those are two recognized tools to assess the frailty in primary care. Both tools use the history and physical examination components to assess the patient's degree of frailty based on the predetermined variables that have been studied and used in researches. So what is the Rockwood Frailty Index? It is a comprehensive analysis, cumulative effect of medical, functional, socio-psychological, age-related deficits, and cognitive effects. So it is like a very complex one. So frailty phenotype, that's the other one, it is the more feasible one in screening, for the screening in primary care. But the frailty index, which is very comprehensive, it is derived from that comprehensive geriatric analysis. It is better suited for management and follow-up. So what we are interested in is with the fried frailty phenotype, that we can use it very easily in our patients to screen for the frailty. It depends on 5 criteria. And the one is unintentional weight loss. Second one, self-reported exhaustion. Third one, weakness. Fourth one, slow walking speed. And the fifth one is low physical activity. I will discuss with those in detail in next slide. These 5 criteria, if somebody with none of these 5 criteria, that person is non-frail. So elderly person with 1 or 2 criteria, pre-frail, and 3 to 5 criteria, frail. So we have non-frail, pre-frail, and frail. That's a frailty degrees. So next one, please. Right. So this, I told you about weight loss. So it is unintentional. It has to be unintentional weight loss, which was in the past 12 months duration. If it is equal or more than 5% of total body weight loss, it is if unintentional loss, we can take as 1. The other one is gait speed. It depends on the height and the sex. So there are several. They are asked to walk about 15 feet, that is 4.5 meters, to walk and see the seconds that they have, their speed. So the third one is grip strength. There's a special dynamometer that is called a specialized instrument to measure the grip strength. That also depends on the sex and the body mass index. The next one, please. Next slide. Yeah, physical exhaustion. That is physical exhaustion, the 4th criteria. That is depend on question here. So if according to the response of that one, 2 questions are asked. According to the response, it is scored 0 to 3. And according to that, we can take that how physically exhausted that patient is. And that is the 4th criteria. The 5th one is low energy expenditure. So that is also measuring with the physical activity questionnaire. So per week, how many calories they spent per week, like. So men and women, there are cutoff values. And those are the 5 criteria that we can use in primary care to screen. So we have to identify that there is no frailty tool that proven superior to another. So it should be appropriate for their patient, demographic, and practicing setting. In 2019, the Task Force of International Conference on Frailty and Sarcopenia Research, ICFSR, developed critical practice guidelines for identification and management of frailty. So this guideline, these physicians are encouraged to develop a patient-specific treatment plan and based on the shared decision making. So management should align with the each patient goals and life expectancy, as well as about the degree of frailty. So these goals should be reviewed periodically when we treat a frailty patient. The next one. So adults in actually the in that International Conference of Frailty and Sarcopenic Research Management on Frailty, they have diagnosed that pre-frail and frail should be offered multi-component physical activity, mainly the physical activity components, balance training and the strength training programs. So that is the main goal. And so healthcare professionals should encourage to refer older adults with frailty with those exercises, resistant training component. And we should have identified about the polypharmacy, the management of sarcopenia, treatable cause of weight loss, and fatigue such as depression, anemia, hypotension, hypothyroidism, vitamin B12 deficiency. So older adults must be offered that they may have unmet needs. So we have to address on those needs as well and give them individualized care. So in that management plan, cognitive behavior and problem solving therapy is not recommended for the treatment of frailty. And vitamin D supplementation, hormonal therapy also not recommended there. But if there is a obvious vitamin D deficiency present in frailty patients, we have to treat. So advanced frailty patients should be referred to geriatricians. Healthcare professionals may offer nutritional or professional protein supplementations. And supplementation can be considered for older adults with frailty when weight loss or undernutrition has been diagnosed. Those are the basic things that in a frailty patient, if we come across a frailty patient in primary care, those are the basic stuff that we have to look for and the management plan. So these are my references, and thank you very much about it.
Okay, so regarding frailty management, so recently we have gone to few words to speak to assess the adult, the elderly care home. And with these three registrars, they have been experiencing what are the common things that they have, being the, the elderly, as well as most of them, although they are elderly, they are not frail. So that is what we want to know. So in such a case, we need to assess who are the frail patients and who are not. So out of 5 criteria that we can, the main 5 criteria that she emphasized. So at least you have to know about those 5 criteria and to come to the diagnosis whether this patient is frail or not. So in such a case, if the patient is in a non-frail or the pre-frail state, so we can, encourage the caregivers or the house home people, close relatives, in order to give them the structured programs like that Dr. Chamila mentioned, even though we don't have such advanced programs, even to encourage for the physical activity as well as for the better nutrition and the supportive therapy in order to avoid them going into the frail stage. With the frailty, the patients are ended up with lot of comorbidities, and on top of that, the falls are the highest risk. So because of that, it's our prime duty, being the primary care physicians, to provide better care by detecting them at correct stage without waiting for them to go into the frailty. So in case of frailty patient, we need to detect them and we need to address the issues pertaining to them in order to not to have any suffering because of the frailty. So this needs the discussion with the home, the family and the caregivers, and interactively you have to provide this assistance that is the prime importance in primary care. So thank you very much, Amila, for your the
Thank you, madam.
comprehensive and as well as it was very clear presentation that you have done on this. So thank you so much. So I invite now Dr. Dilini or Dr. Jayuda, who is going to do the next case presentation.
Madam, I'm going to do, madam.
Okay, Jayada, it's over to you to come with your real case scenario, right? So there are a lot of learning points which we will discuss. Thank you. It's over to you, Jayada.